Well, welcome all. It gives me a great pleasure to start the 8th season of the Mini Medical School. I'm Dr. Larry Robinson. I'm the Vice Dean for Clinical Affairs at the University of Washington here. I want to tell you a little bit about UW Medicine. So if you look at how many people we employ, it's about 16,000 people if you look at between staff, students, and trainees and faculty. And we have roughly another 4,000 clinical faculty out in the community. So we're really working with about 20,000 people in UW Medicine. We are one of the top medical schools in a variety of areas. We've been consistently rated as #1 for training in primary care by U.S. News & World Report. And also for training programs, we've been in the top 10 for a number of areas, including family medicine, rural medicine, AIDS treatment, internal medicine, geriatrics, pediatrics, women's health, and drug and alcohol abuse training. We have many truly outstanding faculty, but I just wanted to point out that we do have 5 Nobel Prize winners. We have 32 members of the Institute of Medicine and 30 members of the National Academy of Sciences. Our goal is to improve the health of the public by advancing medical knowledge, by providing outstanding primary and specialty care, and by preparing tomorrow's physicians, scientists, and other healthcare professionals. Our research has been continuing to increase despite a national slowdown, national reduction in funding. In fiscal year 2007, our grants and contracts awards grew 7% over the previous year. And we are #1 amongst all public medical schools in the country and #2 amongst all medical schools, public and private, second only to Harvard in NIH funding. So what are the goals of Mini Medical School? Well, we want to inform you in an interactive way about the biomedical sciences, all the way from the basic science and to patient care. We want to help you better understand what a medical school does and the resources it has to offer. And we really want to create a partnership with you here in appreciation of the science at UW. Biggest goal is actually to have fun. We'd like to have fun. We've picked people who are fun, and we hope that you see the human side of physicians in medicine. Well, this is the Mini Medical School, but our 2 hosts are not mini at all. These are great people that you'll be spending the next 6 Tuesday nights with. Who are they? Well, it's Dr. Joanne Elmore and Dr. Hugh Foy, your 2008 Mini Medical School hosts. Dr. Elmore is a professor of general internal medicine here at the UW School of Medicine. She's also an adjunct professor in the Department of Epidemiology in the School of Public Health. She's the section head of general internal medicine at Harborview, and she obtained her MD degree from Stanford University School of Medicine. She did residency training in internal medicine at Yale, and then had advanced training in epidemiology from the Yale School of Epidemiology and Public Health. She has a number of clinical and scientific interests. The one you'll be hearing about tonight is accuracy of cancer screening and diagnostic testing. She's also co-authored a textbook on epidemiology, biostatistics, and preventive medicine. And she enjoys seeing patients as a primary care internist and teaching clinical medicine to students and residents. Dr. Hugh Foy, our other co-host, is professor of surgery in the UW School of Medicine. He's the director of the Surgical Specialties Clinic at Harborview and practices general and trauma surgery as well as surgical critical care. He's a faculty member in the UW School of Medicine college system. We have our medical school broken down into 5 different colleges and heads the Wind River College. He obtained his MD from University of Nebraska and did his residency as well as fellowship here at University of Washington. His clinical interests include care of trauma patients, surgical infections, and you'll be hearing about that on the Superbug presentation, gastrointestinal surgery, management and reconstruction of the intestinal tract, and complex wounds and abdominal wall hernias. He was awarded the Margaret Anderson Award for his help and support of UW medical students as a mentor. I won't be lecturing to you much during the rest of these 6 weeks, but you may see me on the road. This is my car. This is Wanda, and one of the guys who makes prosthetics for our amputees helped me make a shark fin for the top out of carbon fiber. So if you see me, wave, and you'll know it's me. Thank you all for your attention. I'm going to turn this over to Dr. Foy now, who will introduce our first speaker.
Thanks, Larry. It's my pleasure to introduce our first speaker, who is John Sheffield. I've known John for a long time. He's a professor of general internal medicine and works with Dr. Elmore as well, not only at Harborview, but for the University of Washington School of Medicine. He's also the Associate Chief of Medicine at Harborview and an attending physician for the adult medicine and the Madison Clinic at Harborview, who takes care of people with immunodeficiency and HIV-related diseases. He received his medical degree from Harvard Medical School, and he did his residency here at the University of Washington and was selected to be the chief resident for a 4th year of internal medicine residency training at Harborview. And we just couldn't stand it. We had to talk him into staying, and we were very pleased when he accepted the job to be a member of our faculty and conducts much of the teaching. He's received numerous awards for his excellence in teaching, and in fact has been awarded what we call the Teacher Superior in Perpetuity, which means that you've been elected by a graduating class of medical students for 4 or more times as their very best instructor. He's also received the Margaret Anderson Award, honoring him for exceptional support and concern for the medical students, as well as the UW School of Medicine Paul Beeson Teaching Award, an Outstanding Attending of the Year Award, which is given by the Department of Medicine for their very finest clinical teacher. John's interests include preventative medicine and obviously the treatment of patients with HIV and AIDS. So it's not only is John a very treasured colleague, he's the go-to guy that I send my most challenging patients to. We're friends on the soccer field, and it's with great pleasure that I introduce to you Dr. John Sheffield.
Thank you very much. That's very generous. Thanks a lot. Thank you very much. I'm used to interactive teaching and prefer being in small groups at the bedside, so this is a little bit different, but fun nevertheless. And it's really a pleasure to be here with all of you tonight. So you're not going to get very far in any school if you're given a handout that has the answers to the questions and you don't get them right. So I'm going to ask you this question. I'm an internist. Do you know what an internist is? Am I a GP? Am I a doctor in the first year of postgraduate training? Am I a family physician? Or am I a doctor for adults? Trademark. So what you do is, if you have your ticker, hit the answer. Go ahead and do that now. Let's make sure the system works. Joanne and I have sprinkled some audience response questions into our presentation, and we want to make it as interactive as we can. So if you've hit it, let me see what you got. There's a scattergram. Okay, so 56% of you guys have the right answer. I am indeed a doctor for adults. Now, this is a very silly title, but the American College of Physicians, one of the leading professional societies of internists, has really struggled with exactly this problem. Everyone knows what a pediatrician is, but no one knows intuitively what an internist is. Many people will turn to us and say, kind of down their nose, so when are you going to be done with your training? And I say, well, as long as I practice. I mean, I'm learning all the time. I am training constantly, but I did my internship in 1989. So they came up, and I don't want to know how many of my dues payments went to trying to come up with this slogan, Doctors for Adults, but that's the best they could do. And such as it is. As a doctor for adults in the general medicine clinics at Harborview, I'm a primary care doc. So for my patients, I coordinate their care, I manage their chronic diseases. I'm the first person that they'll call or email or see about the evaluation of new symptoms. And intersprinkled through all of it, I try to focus on preventive medicine. I try to counsel them regarding healthy lifestyle choices and try to screen to detect diseases before the onset of symptoms. And that's really the subject of the talk tonight. For people who have multiple disease risk factors, we try to manage these and prevent them from developing overt disease. So these are the methods of preventive medicine. In addition to counseling and screening, we give immunizations, and we prescribe certain medications like aspirin to prevent the onset of other diseases in high-risk patients. Now, preventive medicine is very appealing. I think it has a broad appeal to everyone. To patients, there's the idea that you have a thorough evaluation and hopefully get the clean bill of health to obtain advice and counseling, test shots, and medications if necessary. And I think there's this idea out there, Larry, you're driving a Prius, I drive a Prius, but I think there's this idea that the Cadillac or the Rolls-Royce of preventive care is something that people call the executive physical, where the very important person goes and gets an annual head-to-toe physical examination and an annual battery of lab tests. After all, they've got insurance. Let's do the test. And an annual screening procedure. And this idea is certainly reinforced when we hear that our chief executive has gone off not just for 20 minutes, but for maybe 6 hours or an overnight stay annually to get seen by any number of specialists and have any number of tests done. And I think it reinforces this idea that for preventive care, more is better. So let me give you a question, and let's see where your ideas are on that. So here's a 61-year-old executive who presents for his annual checkup. He has no chronic medical problems and no concerning symptoms. His blood pressure is normal. According to the United States Preventive Service Task Force, the most comprehensive group of independent experts who review all of the data available and provide regular updates of guidelines regarding preventive services. According to this group, what do you think they would say should be performed of the choices on this list? A digital rectal exam, B, total cholesterol and HDL cholesterol, C, an exercise treadmill test, D, a chest x-ray, or E, all of the above. Why don't you hit your clickers? So I'll guarantee that the chief executive gets all of it and more, and that might not necessarily be wrong. You know, just because there isn't evidence that's completed yet to suggest that something should be done doesn't mean that it's wrong to do it. Well, let's see what you guys would say. So E would do all of the above. Certainly the chief executive gets that kind of care. What the U.S. Preventive Service Task Force says is something a little bit different, and that would be the total cholesterol screening. So I'm going to take this down, and I'm going to take you to this website to show you what this service is all about. So if you go to the URL that I've listed, you'll get, you can see up, I'm showing you up on the screen, you'll see what this looks like, and you can click on the preventive services, and you'll get to this page. Got several open at once. And you go for the web, and what you can do is search for recommendations. So you can go and actually plug in some of the variables I gave you. A 61-year-old male, let's make him a non-smoker, sexually active. What do they recommend? In the future, please do not show this message. So they grade their recommendations. Those things that they think really should be done are the A's and B's. The things that they're unsure about are the C's and the I's, and the things they don't recommend are the D's. So of the choices I gave you, the only one that they strongly recommend is screening for lipid disorders. There are a few other things like high blood pressure screening. You'll see nowhere on this list a head-to-toe physical exam. The things that they specifically don't recommend, and recommend against, are screening tests that you might use to screen for coronary artery disease, like a treadmill test, an ETT, or an electron beam CT scan in patients who are low risk. And you can go through this website, browse it by topic. You can see that they have put together a list of recommendations on a huge number of diseases. And To go through each of these would be a little bit beyond the scope of my talk tonight. But as you've indicated in your answers, there is a little bit of uncertainty about what really should be the focus of preventive medicine efforts in the clinic. And what I would just come back to and reinforce is that when I'm in the clinic with a patient, my goal is to promote health in accordance with evidence-based guidelines, but these are guidelines. They're not prescriptions. They aren't musts. And I think even more important is to individualize the recommendations that I make based upon a patient's risk factors and their overall health condition, and certainly their desires and values. And because there is complexity to the screening process that I'm going to review tonight, there's often a lot of conflicting information. Screening is really difficult. Different professional societies will recommend different things. So my goals for the next 20 minutes or so are to review principles of screening, hopefully to increase your awareness of the complexities and pitfalls inherent in willy-nilly screening, and ultimately to improve your ability to discuss these issues with your own provider. And that's basically my outline. I'm going to end by talking about hypertension. So what does the U.S. Preventive Services Task Force look for in a disease to try to suggest that this might be something worth screening for? Well, the first thing is that either through a combination of its frequency or its severity, it needs to contribute to a high burden of suffering in the community. And that's pretty straightforward. And when they therefore think about diseases that are candidates, well, they start with the usual suspects. What's the top 10 list of causes of death? And in 2000, it was these. And you start to see pretty quickly that there's a problem. For heart disease, I've just shown you that they recommend against screening for coronary artery disease. I'll touch base on that a little bit in a second. But we do screen for hypertension and hyperlipidemia, diabetes. We counsel patients about diet and exercise and smoking cessation. We try to get around it, but we don't currently have a great way to screen for coronary artery disease. How about cancer? Well, we have good programs for multiple conditions, but the number one cause of cancer death in the United States is lung cancer. And currently, we don't know that we have an effective screening program. And prior trials of chest x-ray screening have actually been negative. People who underwent regular chest x-rays, for whatever reason, probably chance, ended up doing worse than people who had no screening at all. So we clearly need to do better in terms of developing programs that would help address some of these most important causes of death. What else do they look for? Well, by its nature, a good disease candidate for screening has to be detectable before the onset of symptoms. That's pretty straightforward. It's not going to be any good if your initial manifestation of the disease is death. Okay, that's pretty straightforward. Well, so what's the problem with coronary artery disease? Well, sometimes, very often, actually, the initial manifestation of the disease is death. So here's Jim Fixx. This is the man that popularized running in the 70s. His book, the complete book of running, spawned the entire jogging boom in the 70s. Here's a guy who, the day before he died, played a set of tennis with his sister and was said to be fine. The day he died, he ran 10 miles and is said to not have had any symptoms. This is a guy who probably would have done pretty well on a treadmill, I'm thinking. The issue with coronary disease is you've got a relatively wide open artery with a plaque, and through which you've got plenty of blood flow until the moment in which that plaque ruptures, and you've got no flow through that artery. So with coronary disease, sometimes the initial manifestation is a major heart attack or sudden death for some patients. So there's something about this disease, even as common as it is, we don't have really good tools yet to screen for it, which is a good segue to thinking about the tests that we use. So we need accurate tests. They have to be acceptable in terms of their costs and adverse effects. And you've signed up for medical school. I'm sorry, I do have to go through a few statistics. And yet these are pretty straightforward. The qualities that you're looking for in tests, it should be positive in people who have the disease. That's sensitivity, the true positive rate. It should be negative in people who are healthy. That's specificity, the true negative rate. And positive predictive value gives you a little different take on this. Positive predictive value refers to the proportion of patients with positive tests that actually have the disease. Now, in a grid that will elicit a visceral response from our blood pressure measuring volunteers in the back, this is the way that we look at calculating the numbers. So you take a disease that you're thinking about screening, and there's some patients who do have the disease. They go in the left column. Those that are healthy and negative go in the right. You then apply the screening test that you're using, and those patients who are truly positive go in this cell. Those who are truly negative go down here. But what you'll see and what you're looking for is, with this screening test for this disease, how many false positives are there? How many false negatives are there? And the problem with screening is that there are always false positives, and there are also always false negatives. So how often is that a problem? Well, let's use the example of a Hemocult card. So this is a recommended way to screen for colon cancer, it's a Hemocult test. It involves a rather unsavory fishing expedition in which, depending upon the enthusiasm of the fishermen, you may or may not have a sampling error involved. You're asked to sample with this one spatula twice. So you got to use some careful handwork here, and I'm not sure how often that's well done. And the fact of the matter, this is not an accurate test, and let's look at the real-world implications of that inaccuracy. So Hemocults are recommended. They've been studied in trials where patients get them annually for 10 or more years. There's been demonstrated a 33% reduction in colon cancer. But it's really insensitive, 20%. And the positive predictive value is only 2%. So what does that mean? Well, if you screen 10,000 people and only 50 of them, based on the prevalence of colon cancer in the adult population, if only 50 of them have colon cancer, Hemocult's only going to find 10 of those 50. But there'll be 490 unlucky souls who will undergo unnecessary further testing. And even worse off are the 40 who had colon cancer and weren't detected, the false negatives. And this is why Hemocult testing is chosen as the strategy for colon cancer screening. You do it annually because it's insensitive. So false positives and false negatives, this is the reality of most screening tests that we have. Now, Hemocult's kind of an egregious example of it, but still. What else do you need? Well, you need effective treatment, that's for sure. That's pretty straightforward. It doesn't make sense to find something if you don't have anything to do about it. So I won't say much more about that. And the icing on the cake is research. Research is the way to settle all of the discussion between different groups who have various takes on things. And what you're looking for is evidence that implementing a screening program for a certain disease actually reduces illness and death related to that disease. Studies will generally look at the overall mortality in the different populations and maybe quality of life. They'll certainly look at cost. But disease-specific morbidity and mortality is really the coin of the realm. And the way a trial might be structured is you take an asymptomatic test population and you randomly assign individuals to either undergo no screening or screening. You apply your test with all its accuracies or inaccuracies. You treat those who test positive, presumably, and then you follow up over time. What's the disease-specific morbidity and mortality in this group compared to those that aren't screening? And that's what we look for. And to summarize all this, you need the right disease, you need an accurate and effective test, you need good treatment, and it's really helpful to have scientific evidence that shows you it's worthwhile. Well, what are some of the pitfalls? So grab your clicker. Which of the following would you think is a potential pitfall of screening? Might there be false positive test results or false negative test results? Could you diagnose a disease unlikely to result in actual harm? Could you increase healthcare costs without improving overall health? Or E, could there be all of the above? Why don't you hit what you think? All righty. Give you another second, and I'll hit it. Great. All of the above. Excellent. Yeah, I think that's the right answer. So what if a screening test is inaccurate? Well, I've just shown you that false positives and negatives are a problem even for established screening tests. And the need for further testing can certainly create significant anxiety for patients. That's a very real issue that doctors really need to explain to patients before undergoing screening. What if patients undergoing screening are at low risk for the disease? Well, the problem is that if you screen a group of patients who are at low risk, even with an accurate test, you're going to have a much higher false positive rate. So here are the numbers. These are theoretical, and this is why it's important to screen primarily a population of patients who are at highest risk for a disease. So if the prevalence of a disease in a population is 1 in 10, an accurate screening test can do pretty well. The chance that a person who tests positive actually has the disease is pretty good, 78%. As the disease becomes less and less common, when you get down to 1 in 10,000, well, what's the value of the positive test? It's not much at all. So it's really important to primarily screen people at highest risk for a condition. What if effective treatment isn't available for the disease detected by screening? Well, patients might live longer with the diagnosis, but not longer overall. And the problem that's been shown in multiple research studies is that labeling patients who feel well as diseased may actually have pretty significant adverse psychological consequences. What if the disease you detect was unlikely to have harmed the patient in the first place? In our literature, this is referred to as overdiagnosis. Now, this is kind of a concept that I had to wrap my brain around a little bit, but the idea is that you might find something that's really just pseudo-disease. It's not something that is likely to have affected a patient's overall survival or quality of life. Is that an issue? Well, actually, it is kind of an issue. So here's just a little snippet about prostate cancer. So prostate cancer is a heterogeneous disease. Some cases are very aggressive. It is the #2 cause of cancer death in men. But other cases are very indolent, very slow to grow, maybe not going to spread at all. And autopsy studies show that microscopic non-invasive forms of prostate cancer are actually very common. For men in their 50s, autopsy studies might suggest that about a quarter of men would have harbored a microscopic focus of prostate cancer. If men survive to their 90s, maybe all of them, by some estimates, have a microscopic form of prostate cancer. Now, clearly not all men in their 90s die of prostate cancer. So if you screen aggressively, are you going to find something that maybe wasn't going to hurt somebody? It's maybe a little bit more than a theoretical concern, but it's certainly something that goes into the debate. And the problem is, that I'll show you schematically, is that patients who are asymptomatic with this very non-aggressive form of a cancer are more likely to be prevalent in a population at any given time when you're screening them. So on this schematic, this short bar represents a patient who's not going to live very long with this condition. From the time of disease onset to the time it kills them, it's very quick, it's very aggressive. Other lifelines are longer. And the way this argument goes about the possibility of overdiagnosing a condition is that maybe in the population, these patients with the more indolent form are going to be the ones who are more likely to be picked up with screening. So it's at least a theoretical concern that you may be biased to picking up the cases that really weren't going to hurt people. And then, of course, the issue is that once you've diagnosed a cancer, what are you going to do with it? Well, many people are going to be treated. And the treatment is not benign, as I've shown up here. So with prostate cancer, we don't have any completed research studies to really tell us where we should be going on this debate. And that's why it's such a difficult issue to decide whether or not to pursue screening with men. We know what the potential harms are, but we're not as clear about what the potential benefits are. So just to summarize, I've reviewed several potential pitfalls of screening, the issues of false positive and negative test results, the possibility of diagnosing a disease for which effective treatment isn't available, diagnosing pseudo-disease, labeling healthy patients as diseased, potential harms of testing and treatment, and I haven't really gone into increasing costs without improving health, but that's certainly a problem. So I just want to wrap by looking at hypertension and seeing how it squares with these considerations. Is it a disease that causes a high burden of suffering in the population? Yeah. There are 50 million adults who have hypertension. It's a major risk factor for stroke, renal failure, heart failure, and coronary heart disease. Is it detectable prior to the onset of symptoms? Yeah. Unfortunately, even after you've diagnosed it, patients often don't have symptoms. That becomes an issue of getting them to take their medicine. If they don't have any problem, why take the pill? Do we have an acceptable and accurate test? Clearly. Here's Andy Blair, who helped me prepare these slides. I'll thank him through this way. Do we have treatment that's available and effective? Absolutely. And has it been studied? Yes. So with treating hypertension, there's a 40% reduction in stroke, 25% reduction in heart attack, and greater than 50% reduction in heart failure. And just to throw one more statistic at you, the number of patients you need to treat for hypertension for 10 years to prevent one death is 11. And I'm not going to throw a lot of other stats at you, but that in our field is an incredibly low number. So this is clearly something that we should be screening for actively. And that's why we set up the screening booths here tonight. So the U.S. Preventive Services Task Force makes this a grade A recommendation. Everyone should know what their blood pressure is. So a last question that I'll ask. Do you have hypertension? Now, if your blood pressure happened to be elevated when you came in, you don't necessarily have hypertension. But do you have a prior diagnosis of hypertension is really what I want to ask. So why don't you give us a read on that with your clicker. I'll give you a few more seconds and see. So no, 77%, yes, 11%, don't know, 12%. I want to remind you that when we measure your pressure, we're not necessarily diagnosing hypertension. Hypertension is a diagnosis made over time. You need multiple readings at separate times to really confirm or deny whether or not you've got hypertension. But it's something that we certainly think is worth screening for. So let me summarize my talk. I've shown that screening reduces morbidity and mortality for many diseases, or I've alluded to that, including hypertension. But we really need better methods for several major diseases. Even effective screening programs result in false positive and false negative test results. And ultimately, because there is uncertainty and conflicting recommendations between professional groups, when data regarding outcomes of screening are scant or inconclusive, providing adequate information to help patients decide whether or not to pursue screening is a major challenge. But I hope that through my talk, you'll leave tonight with a little bit better understanding about some of the complexities involved and why there might be some differing opinions, and that when you're in the exam room with your provider, you'll be a little bit better informed about what choice you're making. And with that, I'll thank you very much for your attention and usher us to a break, during which time, if you haven't already had your blood pressure measured, we definitely encourage you to have it done. Thank you very much.
Now you're going to feel a bit about pressure, pump it up.
Yeah.
And see if the number is consistent with the one you got yesterday.
What's the ideal pressure?
What's that?
The ideal.
Around 110/80.
Why I volunteered to do this unintended.
is why you do.
Good question.
That's okay. I'm a surgeon. I'm not an intern. I would. Hi, Larry.
Is your blood pressure up now?
Yeah. Well, we'll see.
ahead and just
Yeah,
relax.
we'll see. See how it compares to 2 weeks ago.
Do you have a blood pressure card? Do you keep track of your blood pressure on your own time? Or?
No, I should.
Would you like one?
Well, why not?
Based on what we're doing right now. Of course, you're welcome to come back at the break.
All right.
So, I actually got.
This program really gives you all the tools that you're going to need to prepare for medical school. It challenges you academically and personally to become a better student and a better future physician.
Getting in the field of dentistry is more just a dream. Now I actually feel like I'm in the pipeline.
They're talking about radiology, surgery, pediatrics, and all these different areas of medicine that I hadn't heard of before.
I was not sure whether to go dental or med, and just coming here and being able to be in an OR in the hospital, being with doctors, the exposure, and opening myself to different experiences has helped me decide what I want to do.
The SMDP, it stands for the Summer Medical Dental Education Program. And what it is, it's a 6-week summer enrichment program that invites college undergraduates to spend that 6 week with us in order to prepare themselves to be more competitive for either medical school or for dental school.
It's a program that we administer on 12 sites across the country. There are 80 participants in each site. 9 of the sites are combined medical dental sites. 3 of the sites are medical only sites. And the goal of the program is to bring the best students that we can from across the country who are interested in pursuing careers in medicine and dentistry, who are largely from groups underrepresented or disadvantaged.
I'm from a family of 15 children. I'm the 9th. My parents came from Mexico, and I was born here in Toppenish. I worked in the fields since I was about 4 with my parents. I only worked there like 3 or 4 years. In elementary, I did really well, but it was middle school that really challenged me. Because in elementary, there was bilingual teachers, and in middle school there was no bilingual teachers because my first language is Spanish. Once I went to high school, it was much better. College, again, was really tough. It was like a big jump there from high school to college for me.
And there's emerging research that's coming out.
Going away from my family when I had to come here, I hardly get to see them because I'm very close to my dad. I'm the first one to come to university, the first one to go into medicine.
I grew up in Lancaster, California. It's a suburb of Los Angeles. I'm 22 years old. That's because I took some time off to go to the Marine Corps and serve my country. I continue to serve the military to this day as a reservist. My goals are to get a DDS and become a dentist so that way I can go and help the underserved communities. Though I had done well in high school, I went to college with the wrong mentality, but after coming here, they taught me the study habits and what have you, what's necessary to elevate yourself to the next level in the hard sciences.
Look from back here.
I want to go back and help the urban youth who can relate to me. That's why I try to keep my slang and not try to become too acclimated.
I grew up on the Acoma Reservation. Growing up on the reservation is really close-knit, and I had to make the decision to leave the reservation to get higher education in Massachusetts, and I really feel that really helped me because I was able to know, the disparities on the reservation, and that acts as a motivation when I'm in college. When I do get homesick, I think, I want to help my family. And my family includes, the other community members of Acoma and Jemez and just Native American people.
My name is Karina Chavez. I go to UC Berkeley. Currently, I will be taking organic chemistry. I have 4 more classes to take in the sciences. I'm a psych major, so I really enjoy psychology. I'm planning on going to dental school, hopefully in 3 years.
I'm half black, quarter Mexican, quarter white. Really proud of all my cultures. My mom raised me and my sister. I watched her go from welfare to a full-time job, and then she went into nursing school. We didn't have a lot of money. Grew up on commodities and cheap food, but my mom always made sure there's food on the table, milk in the fridge, and she never let us know that we were at a disadvantage. We were always happy. She always made sure that we were able to do things and pursue them.
I had pretty much come to the decision that I wanted to go into medicine, and then in my junior year I applied to the program and I came and I stayed here in Seattle for 5 weeks, and I was just afforded some opportunities to observe surgeries and see trauma, and that was just amazing for me because it was just like full immersion into medicine, and it was just full on and just amazing, and definitely cemented my decision to pursue medicine.
The double bond actually splits up into 2 bonds.
Students are exposed to an array of science and math courses that emphasize oral communication skills, writing skills, and it's all designed to bring them to the door of medicine and dentistry better perhaps prepared than they otherwise would have been, but certainly with confidence that they can achieve admittance to medical and dental school.
Remember, everybody's face is different.
I'd compare this program to boot camp. It's actually an academic boot camp. It's the same thing that I did in the Marines, except for now it's academic. Instead of running and push-ups, I'm reading and studying, writing papers and reviewing my physics and chemistry. From 8 a.m. till 5 p.m., it's just academic grind.
Yeah, no pressure.
No pressure.
It's hard sometimes to push yourself and really reach those higher levels of potential that we have. What these programs do is really push us to that, and then we kind of see ourselves that we won't break and we won't fall apart, and that we actually do gain a lot from it.
Oh, I get it. You just go back around. It's a full schedule. It's a little overwhelming on first, but you learn how to balance things, and I think I'm pretty good at it.
I really like it so far. It's like training for a marathon before I go back to school. I've really learned a lot from taking physics courses to the organic chemistry to writing and composition.
Now, at this point in time, how do you manage stress in your life?
The classroom stuff to me is just, it's wonderful. I love to hear about coping with the stress, about, every class that they have just sucks me in, and I just want to learn and learn and learn.
The nightly tutoring sessions were optional for those who need the extra help, and because of the intense scheduling, a lot of students do need the extra help.
The tutoring is wonderful. It wasn't until I came here that I realized that you can actually ask people for help, and there are people willing to help you get there.
Apart from the academics enrichment, they do have the hands-on experiences here, and their first time experiences. So suture clinic for one thing, where they're sewing up pigs' feet, and then they'll probably later do that in their medical school and dental school training.
I'm going to go ahead and enter the patient's right-hand side.
We also have some patient intubation simulations. Our students are in there playing with mannequins, learning how to intubate a person.
It works. We just saved his life.
Though they won't practice this on a real person, they do get the first hands-on experience.
Being here and just being in a class where everyone's a minority in some way or form, it's just great. You just feel at home and everyone respects each other, and this program has really helped me as a person.
It's great that a program like this exists. I mean, where else do they fly you out here and pay for your food, pay for your room and board, and give you a stipend, and all you have to do is read books? You're getting paid to better yourself. Can't beat it.
Well, let's see, I've got a hernia procedure, an exploratory lap.
The enthusiasm that you see in their faces when they come back from witnessing a simple surgery is quite dramatic and something that I think that they'll truly remember.
Each student has the ability to visit the Harborview Emergency Room or the UW Medical Center operating room, or even go up to Mount Vernon to visit the microcamps.
And these particular camps are for a lot of the migrant farm workers that are in our local area for a very temporary period of time. And we offer them blood pressure screenings, diabetes screenings as well. And we also do tuberculosis skin testing on them as well.
I could not imagine the magnitude of poverty that I saw there. The living conditions were just, I mean, they were chicken coops and people lived in them. When I went there and I was with those kids, it made me look around and I go, you know what, this is the reason why I'm going to medicine. These kids and their lives, that's my drive. This is why I'm here, and this is why I'm gonna be a pediatrician. So it's really helped me cement my reasons for going into medicine.
I found doctors from this program who have been able to help out their communities, go back home, and help the underserved, and I think that's great to be able to give back to society.
I have a great mentor. He's a radiologist.
We use magnifying glasses if we need to.
He shows me and he explains to me what he's doing.
Take a look at this. Do you see anything that kind of pops out at you as being abnormal?
When I see an x-ray of breast, I actually know what we're looking for. He recommends treatments for what he finds, so I kind of know a little bit of that. The mentoring's great.
Keep an open mind. Don't focus in on one thing too early. You're going to have a lot of fun in medical school deciding what you want to do.
Well, back home, there's a lot of Hispanic people that work in the fields that don't really like to go to the hospitals or the clinic, and I'd like to change that.
You don't realize that a DDS is actually a doctor of dental surgery until you have the opportunity to shadow dentists, and dentists are doing surgery every day. The mentors are great. They let you get real close and see everything that's going on.
It's given me so much more confidence. I mean, the road to medical school and stuff, it's challenging, and for every negative thought I had, there was always more people in the program there to tell me that, hey, you can do this, you know, to support me, encourage me, and that's just really helped me tremendously.
It's a program that allows them to explore their options, and we're about trying to help students become good citizens and to select a career that will make them happy and that will allow them to make a contribution. We hope it's in medicine and dentistry, but if not, we just hope that we've helped them along the way to making a decision that will best suit their needs.
This is what a student needs to do, get experience one-on-one and see for themselves, and just being there really helps decide if that's what you really want to do.
Follow your dreams. If it's going into medicine or going to any kind of teaching or anything that calls to you, especially if it's calling you to help your people.
It's helping me get an overview of the courses I have to take to get into med school. It's like a little spark that's going to keep me going. now I definitely know I want to go into medicine.
I love this program. It's the best thing I've ever done.
But if you have any interest in medicine, I would definitely recommend that you apply, do it as early as possible, and come and be prepared to experience an amazing, amazing time.